Good day. My name is Dr. Christine Velasquez together with Dr. Juliet Cervantes from the Department of Internal Medicine, St. Luke's Medical Center, Global City, Philippines, presenting our e-poster for the case report entitled Not the Usual, Diagnostic Dilemma in a Case of a Large, Well-Differentiated, Non-AFP Producing HCC with Atypical Features on Non-Invasive Imaging. Here is our disclosure slide. To begin, we have a 66-year-old male hypertensive with a 3-month history of progressive right upper quadrant pain and abdominal enlargement. He also has easy fatigability, anorexia, and weight loss. Here you can see the other pertinent details in his medical history and the summary of his physical examination findings. The patient was initially seen in another institution, where blood tests were done as well as imaging. Initial results show a low hemoglobin count, prolonged INR, elevated liver enzymes, and a previous hepatitis B infection. Tumor markers were done, namely CEA, CA19-9, and AFP, which were all normal. Imaging with whole abdominal ultrasound and CT scan with contrast showed hepatomegaly and multiple liver masses with malignant characteristics. Hence, whole body PET CT scan was done, which concurred the initial findings but revealed no hypermetabolic malignant looking lesions outside of the liver. Percutaneous biopsy of the liver was done, which showed equivocal results with atypical cells and this type of IHC profile. The patient opted to have second opinion in our institution. Now, based on his initial workups, our goal was to establish a definitive diagnosis. This was our initial working impression, and here are some other concomitant issues that were managed during admission. The patient underwent a series of diagnostic imaging tests to guide us with the diagnosis, starting with the ultrasound, which revealed the actual size of the liver and the nodules. On the background of chronic liver disease, fibrosis was staged using liver elastography, which showed F4 result. Four-phase dynamic CT scan of the liver was done to describe the lesions. Results were interpreted using LIGRAD scoring. CT showed several arterially enhancing lesions with no washout, the largest of which was found in segment 5 and 6, and this was labeled as LR malignant. Segment 8, 4, and 3 was labeled as LR4 probable HCC, and segment 2, LR3, intermediate for HCC. Impression was a typical HCC, combined cholangiocarcinoma HCC, primary or metastatic liver disease. MRI of the liver was done to improve detection and characterization of the lesions, showing early enhancing foci in segment 8, 4B, and 3 without demonstrable washout and early enhancing capsule. The results from the MRI were same as the CT. Hence, since both imaging were inconclusive, a laparoscopic guided biopsy with frozen section was planned, as this allows localization, visualization, and prompt hemostasis. Here are the intraoperative findings, and the biopsy of the liver mass showed well-differentiated hepatocellular carcinoma, and on the right you can see the different immunohistochemical stains used. The patient was classified as advanced stage by BCLC from his lesion, Child-Pugh B score, and functional capacity of ECOG-1. Hence, started on systemic therapy with lenvatinib, 12 milligrams per tab once daily, which was tolerated by the patient. Here is our final diagnosis for this case. To summarize, liver masses present usually with clinical dilemmas, and one of which is because of the complexity of the hepatocarcinogenesis. The classical features may not always be present, and the masses may present with atypical imaging findings. When these are inconclusive, biopsy becomes necessary, as the primary goal is to establish a definitive diagnosis to guide with the management and treatment options. Thank you for your time. Thank you for listening, and have a nice